My name is Hartmann Wellhoefer. I work at Shire as the head of medical affairs for genetic diseases franchise, which in our case means I'm responsible for Fabry, Gaucher, Hunter's disease and hereditary angioedema. So Hunter's disease is one of the lysosomal storage disease disorders, and we were the first to introduce a treatment for that, enzyme replacement therapy, basically producing a biologic that replaces what the body either can't produce or not correctly produce. So that the name is Elaprase, and that's an infusion every 2 weeks, and treats these patients from a somatic perspective. It doesn't cross the blood-brain barrier. We're very excited. We have a phase 3 pipeline compound where we've just fully enrolled the study, and this is actually a combination of a modified version of the product Elaprase for use in the intrathecal environment. So it's infused via a device that's implanted into the intrathecal system and injected through a port so that you basically circumvent the blood-brain barrier. The big hope for us, and hopefully we're going to have data from that pivotal study later this year, is that it also addresses the neurological symptoms that are associated in 2/3 of the Hunter patients. The GoShe survey, it's an abbreviation for GoShe outcomes survey. It's basically a real-world data collection of patients who either are diagnosed with Gaucher disease and or are treated with VPRIF, our other enzyme replacement therapy that we have for Gaucher disease. We crossed last year the 1,000 patient enrolled milestone for that. It basically collects data from the initial pivotal trial program that we did with VPRIF and extends that into the real world setting now as the patients are treated with a commercial product. One of the things that we really are very excited and interested to look at, as this is a very long-term and very large database for Gaucher, to look into how the phenotype of Gaucher is changing through the treatment versus the relatively well-established natural history. So that's one of the things that we're really very interested in. That's one of the tools that we want to look at. We don't have the data yet, but this is one of the things that we're trying to get in terms of insights out of the real world now, as Gaucher might have evolved through the changes that come through therapy, because I think it's fair to say that enzyme replacement therapy in general, and for Gaucher in particular, has really changed the phenotype of Gaucher patients. One of the things that we are seeing more and more, that from a children's disease it's become an adult disease, because kids grow up, become adolescents, become adults, and so the phenotypes and potentially the symptoms as well as potential comorbidities or associated diseases might change in this population, and this is a very new finding because it's induced basically by the therapeutic option you all of a sudden have with enzyme replacement therapy. Fabry number 3 is actually one of my personal most favorite diseases, is the wrong word, but I think it's a fascinating disease because you have such a variety of Fabry disease, from the little boy that has belly aches and pain in his fingers or toes, to a young lady who might have a premature stroke at young age. So again, the phenotype in Fabry is really a huge variation. The challenge that we have there is demonstrating efficacy, and with our outcomes registry for Fabry, that is called FOSS Outcomes Survey, we've been able to demonstrate that there might actually be a morbidity and mortality benefit associated with Replagal and the therapy, the modern therapy. So we saw evidence that people live longer, have less renal decline, renal function decline. And we are also seeing, and that's one of the posters that we are presenting here at World, that if you treat earlier, in this case we've done an analysis, if you treat within 2 years of diagnosis or symptom onset, that you actually get less disease progression, so the Replagal works better, is more efficacious, so earlier treatment is better for patients with Fabry disease. It's a very crowded space, and we are part of a very significant part of that crowd. We have a couple of approved compounds. Firazyr was the first on-demand subcutaneous acute treatment for HAE. When we acquired Viropharma, we got Cinryze for the prophylaxis of HAE, and when last year we acquired Dyax, we got Kalbitor, which is only available in the US. And very importantly, and we're very excited about that, we got 643, which is a fully humanized antibody against plasma kallikrein, and we have very high hopes that that might actually transform the prophylactic treatment of hereditary angioedema and really be a very convenient, very powerful prophylaxis for HAE.
How will it transform, theoretically?
Theoretically, yes, with all the disclaimer that we don't have the phase 3 data. The trial is fully enrolled last year, and we're expecting the data later this year, but it's a subcutaneous formulation, so it's basically 1 or 2 milliliters subcutaneous that you might need either every 2 weeks or maybe even just once a month potentially. And based on the phase 1 data, that 1B data that have been presented last year for the first time, there is the potential that you really could almost wipe out the risk of attacks. And the revolution in that, from my personal perspective, if you're a patient with HAE, you never know when the attack hits you. It's like lightning strikes. It's totally unpredictable. And these patients live under constant fear. If some event in their life happens, whether it's an exam or they get married, they are very anxious that they might get an attack. And so that potentially could really alleviate that fear and the anxiety. Depression rate amongst HAE patients are very high, so the comorbidities associated with the disease, the symptoms are not only with the attack but also between the attacks. So I think that is, if this prophylaxis works as we hope, this prevention of attacks works as we hope, that really will change patients' life, and they have to take a little shot just every 2 or maybe every 4 weeks only. So the invasive piece is very limited. But if they have to do Cinryze prophylaxis, they have to do it every 2 or 3 days, an infusion. So that's obviously quite inconvenient. It works very effectively, but it's a difference.